To say, if given the chance to drop on an hour plane and see you in person, I would have happily done that if able, but next time.
Next time. Well, we definitely have to get back to in-person meetings, I've got to say. Okay, well, I guess it's 7:30, so we should start. I just want to make sure that, okay, great, that Millie started the recording. So good morning, everybody. Thank you for joining us again this morning. It's my pleasure to have with us a good friend, Kevin Croce, who's the director of the CT and Complex Coronary Artery Intervention Program at Harvard. And I think we asked Kevin to join us because, you know, we're using more and more intracoronary imaging, certainly in our lab and OCT, and I still consider myself a student of OCT, and I'm hoping to learn from Kevin how to use it in a more practical way every day in my cath lab. So on to you, Kevin. Thanks a lot.
Thanks, Azim. Appreciate it. Well, welcome, friends and colleagues. I know many of you. It's great to see you virtually. I wish you could be in person, but hopefully sometime soon. Thanks very much for the opportunity to present. This has been sort of a fun journey for us. I'll take you through a little bit of our experience with OCT in the near term, and then share what's a relatively new initiative in terms of how to do an OCT-guided PCI that came out of a collaborative effort that several of us got together to work on this past January. And so I'll just dive right into this, you know, effectively thinking about why would I use OCT to support a PCI? And these are just sort of overarching questions. You'd hope to be able to improve outcomes. You'd hope to be able to make PCI more precise, potentially faster, easier. And at the end of the day, it'd be great if we could show an economic benefit. And there's varying points of data across all these points that we'll go over the next 45 or 50 minutes or so. And so we think a lot about what the barriers to adoption of intravascular imaging are. When I was a fellow, the statement that there's really no proof that imaging impacts outcomes is true. And a lot of people have been practicing the same way for a long time. And it really is, I think, unfortunately, a well-held belief in interventional cardiology that the angio is good enough. And these are things in terms of the database which have evolved significantly over the past several years. You know, you're a high-level practice, and I think I won't belabor this too much, but as you're aware now, there's several randomized trials that show the value of intravascular imaging in terms of improving patient outcomes. IVUS-XPL, which was published in 2015, demonstrated that intravascular imaging cuts in half the MACE rates in patients undergoing PCI. And Ultimate, which was presented at TCT about 20 months ago now, which was an all-comer study, actually demonstrated that intravascular imaging, numerically, the two randomized trials are almost the same. Target vessel failure and MACE are cut down in half. And this is largely driven by reduction in target vessel target lesion revascularization. So as you know, as we amass a database in the space, the newest meta-analysis published this year, which now includes IVUS-XPL and Ultimate, demonstrates a significant trend toward a reduction in a MACE event we really care about, cardiovascular death. And so I think that, you know, the randomized trials support imaging, the meta-analyses show a significant trend toward a reduction in the big outcome, which is cardiovascular death. And interestingly, lots of registry studies, pretty large ones, actually track with this. Registry from the UK of 6,000 somewhat complex patients. Intravascular imaging got you larger mean stent diameters, better outcomes from a cumulative incidence of MACE, and then a 75,000 patient registry from the UK demonstrated mortality benefit to IVUS and OCT compared to angio-guided PCI. And so I think, you know, the data really has come a long way in the 10 years that I've been in practice. And so this is a really cool slide, which I got from Gary Mint, and he shows this regularly, often with a little bit of an off the cuff of, you know, come on guys, there's a lot of imaging data now. And this is just one slide which shows, you know, IVUS and OCT as color coded. And I think, you know, Gary very nicely makes the point that you don't just have to look at one study or one meta-analysis. The bulk of the data really is insurmountably non-challengeable now in terms of imaging having a significant impact on all sorts of PCI outcomes that we care about. So with that in mind, you know, based on the data, everybody in the US should get an image-guided PCI, right? Well, unfortunately, that's not the case. This demonstrates the trends between 2015 and 2018, with about a 14% penetrance of imaging supporting percutaneous intervention. You see this goes up about 1% per year. You know, it's a little bit dismal, but one of the cool things is the newest bit of data in this point is that we've got a significant jump between 2018 and then 2019. And this shows that in the United States, we really went up 10% in 1 year. And I think that's in response to the fact that the data is so strong. And Azim and colleagues, happy to make this discussional. So any thoughts or comments you have, please interject. One of the things that I have a hard time wrapping my head around is the United States is a pretty good healthcare system, as is Japan. But if you look at the number of PCIs that are done with intravascular imaging in Japan, it's inordinately higher than we're doing in the United States. So two really good healthcare systems, but a major discordance in terms of the use of imaging to support PCI. This may be in part related to things like reimbursement or habit or potentially training, but it's something that I really don't have a lot of clarity on. I think thinking about what the right size number here for the United States is something I'd love to discuss with all of you as we kind of go through this journey in our practice and what we've been doing up in Boston. Thoughts on that, Azim and colleagues? I mean, I really don't have a lot of clarity on why I work 24% and Japan's at 95%.
Yeah, you know, we have some Japanese colleagues on, so maybe they'll comment. I think it's a lot to do with training and the way, you know, the Japanese training is that all, you know, all my Japanese fellows, and I've had a number over the years, are all so fluent in any form of imaging. That's just an integral part of their training. I'm sure there's some sort of reimbursement part as well. You know, Europe was really bad. You know, we went from labs like my own in Milano where, you know, me and Antonio were 80% imaging to labs where, you know, you see that 6%.
Yeah.
And that's very concerning. As regards to the US, Kevin, I've been asking this question a lot. I mean, what is reimbursement in the US for intracoronary imaging? Are we reimbursed, and to what degree?
Yeah, so I think, you know, the hospital gets reimbursed a little bit, and there is now a professional fee reimbursement for all types of imaging. And I think the hard part is that, you know, in the United States, per case cost inpatient is something that's focused on, and there's not a big incentive for improving outcomes at 1 year, 2 year, 3 year. And those longer term outcomes are not part of the quality equation. And so people are looking at keeping in-hospital costs down and really getting a margin between what's paid for, especially on Medicare patients, versus what's spent on cases. But I think we need to pivot that conversation. And actually, that's probably the last slide in this presentation. We could talk a little about how to do that for you know, high impact academic centers like yours and ours that actually can hopefully drive some of this conversation.
Right.
So you make a great point. I think, you know, this next slide, Azim, actually speaks to that. It's a different data set. It's from the National Inpatient Database. And I'll just have you focus on this bottom right-hand panel. This is effectively percentages. It's a number of hundreds of imaging cases per 1,000 coronary interventions. And you see most hospitals are clustered on the we don't image at all, the 0% axis. So that number of 14% or 24%, it's not like all US PCI centers are using that number. It really is most hospitals doing very little, and that average being driven up by some hospitals being really far out on the curve. And for a long time at the Brigham where I practiced, I was sort of out in the 60 to 70% range, and most of my partners were clustered down here. And so, you know, you could potentially look at this like I'm reading the data differently, or I'm just using a lot of catheters and wasting money. And so I think, you know, it's interesting in that over time, what's been really cool is that since Ultimate was published, my cath lab director, Benny Shah, who's a good friend, came back from TCT with a bunch of us, and we really said, all right, you know, I think the data's there. We need to make a programmatic, concerted effort to increase our imaging on whole. And I think really what we wanted to do is to try to standardize it. So Benny asked my partner, Brian, who works with me in our complex PCI program, just to come up with a bunch of posters. And these now hang in every cath lab in our hospital. You can see the little light switch here. They're pretty big. And it really is just a roadmap in terms of how to do a modern OCT-guided or IVUS-guided PCI. And so, you know, based on the reading of the data and the fact that, you know, I was sort of out on a limb alone, we tried to kind of get the entire community to grow into a practice that I think was supported by the new data that came out about 20 months ago. And so with that, we also started to do stuff like at our M&M in Cath Lab conference, where we review utilization and then outcomes. We started to track imaging percentage by month. And so this is part of our quality initiative. We look at this, and you can see with the concerted effort to standardize things, get everybody on the same page, the imaging percentage at our hospital grew significantly on the heels of Ultimate. And so I think it's, you know, it's been a nice journey in terms of how we as interventional cardiologists evolve practice in the face of new information. And that's one of the fun things about our job, and it keeps it fresh. Is this something that you guys track at Cath Lab conference, Azim? I don't know if this is unique to us or everybody kind of looks at percentage imaging.
So it's interesting. It's something we've started recently. Or I've started recently because it's something I feel is really important. You know, I'd love to be able to get to the kind of levels that you are doing too. It's, you know, it's interesting how it's very variable per operator too,
Yeah,
right? In the cath lab, there's some operators, some of my colleagues are using OCT in almost all their PCIs, which is fantastic. Others almost never use imaging. So I think what we're trying to do is trying to create a level of consistency. I like the charts you have. And so I'm probably going to be asking you to share that with all of us.
Happy to, yeah, I will.
So we can maybe modify them slightly and reprint them for our own cath labs. That looks great, because I think if you have it simple on the cath lab wall in your face, right?
Yep.
That really helps.
Yeah, it was cool when Benny posted this on Twitter. Over the following week, we got about 30 requests for the PDFs. So we have them. They're in a Dropbox. I'll send you the link.
Awesome.
The unfortunate thing is, right as Brian made the OCT optimization, which is kind of based on Illumine 4, that's right about when we came out with the MLD Max workflow. So we need to revise this one. But there's actually some really cool teaching tools that we helped Abbott to develop in terms of one-pagers that'll go through the MLD Max workflow. And so we'll provide you those, and you can actually very easily have those made into a poster to have this updated. But we'll give you the IVUS one. It's based on Ultimate, and it's pretty straightforward. I'm sure you're well versed in it. But to your point, it's just nice to have it there as a reference for anybody that's willing to do it. And so with that in mind, then, really other barriers to adoption of imaging is a long-standing belief that the angiogram is good enough. And I challenge this quite significantly. This is a study which came out a long time ago in Circulation, but it has a lot of relevance today. It's quantitative assessment of lesion severity versus physician assessment. You can see there's huge inter-individual variation in terms of how we read angiograms. And we always joke, some of us are very aggressive in terms of our stenosis grading, and other of my colleagues can be very conservative. And so there is even a style to this that's inexact. And it's unfortunate that it's inexact, because this is an important thing. We make important decisions for patients all the time based on what I think is a pretty blunt tool. Even in terms of the fact that angiograms are a little hard to read with regard to sizing, many of us don't even agree on stenosis severity, varying 50% to maybe 80% for the same lesion. And so that's potentially a problem. This is an older slide, but it's still, I go over this early in the year with all of our interventional fellows. This correlates QCA identified stenoses in the 50 to 70, 70 to 90, or greater than 90% range, and what the FFR value is of these lesions. And you can see in the 50 to 70% range, where we often defer, 35% of these are abnormal by FFR. And in the 71 to 90% range angiographically, 20% are normal. These are places where we typically treat. And so we're under-treating a large proportion of patients, and we're over-treating some proportion. You can see there's a lot more dots in the 50 to 90 range than there are over 90%. As you get to 90%, the angiogram actually becomes somewhat predictive, which is nice. And so the angiogram is not a great tool, as you well know, for determining who gets treated. Similarly, in terms of optimizing PCI, we know that when we use intravascular imaging, when it's used in a case, the stent minimal luminal area grows by 1.6 millimeters squared. This is a meta-analysis looking at this. That's a huge number. That's a really large growth in the area. So I think it just backs us into the idea that the angiogram is probably not a great way to optimize our stenting result. It's a beautiful study of Alan Jeremias published last year. It's called Define PCI. I'm sure you're aware of it. Effectively, the way this was done is that patients had an angiogram-guided PCI, and when the doc was done at the end of the case, when there was no stenosis greater than 50%, the investigators did a blinded IFR pullback. And when docs thought they were done, a quarter of the patients still had an abnormal resting index defined as less than 0.89. And of that quarter, 80% of them had focal disease, which was amenable to treatment. My fellow Moda, who's going to be one of our complex PCI fellows next year, made this slide for me. It's amazing. A quarter of these patients, a third of these patients had abnormalities that were focal proximal to the stent, a third distal, but about 38% of them actually had the major IFR drop in the stent that was just placed to treat the patient. So I think, knowing when you're done with the PCI, using the angiogram is also inexact. And I think, much as you guys probably have, we've been using a lot of resting physiology now to map out where to treat. And Alan and his colleagues are now designing a trial to actually use resting pullbacks to decide where to treat, with the goal of optimizing the resting index at the end of it. And that's called Define GPS, which is going to be starting hopefully in the next year, to see if we can impact outcomes using this. And so the angiogram is a pretty blunt tool, even to know when you're done with your PCI. And that was sobering, because I think, will we someday be treating to normalize resting indices? That's a question that I think the data will give us a shed light on over the next couple of years as they finish the Define GPS study once it gets started. And so the other potential barrier in imaging is, extra contrast is an issue with my patients. This often comes up with OCT. We'll talk about this. Radiation dose, procedure time, cost, all too much. Going back to the idea that the angiogram is good enough. And so we're pretty excited because we've been participating over the past year and a half in a LightLAB OCT efficiency project. This is going on at 12 centers, encompasses about 50 physicians, and it's actually a workflow study. It's meant to develop best practices in terms of how to use OCT to guide PCI. And the cool part about this is this workflow study follows the MLD Max OCT workflow we're going to talk about in detail. And so we're looking to see if OCT can make us better, change our decision-making, and potentially have some benefit in terms of procedural efficiency, equipment use, contrast, radiation, and time. And we're in the early part of this, but I'm excited to share next week, Hiram's going to present our first bit of data from this, where in phase 1 of the study, we're going to look at the impact of OCT on decision-making during coronary intervention from this LightLAB program. This is sort of the phase 1 data of how an early experience of adopting the MLD Max workflow changes what happens in cases. I can't share with you the slides from this yet because they're embargoed until next week, but I am able by contract to show you my own personal data. The way this is done in the LightLAB phase 1 is I have to call out based on the angiogram the size and length of stent that I'm going to use to treat the lesion. Then I do a pre-PCI OCT, and I actually make my decision based on a much more high fidelity bit of information is what the OCT shows me. And you can see that either based on stent diameter here or stent length, a pre-PCI OCT changes my plan with regard to stenting 76% of the time. And so I was really sobering. When we started this project, I'm like, yeah, I've been doing OCT a long time. I don't think that it's going to change much of what I do, because I'd always thought that I recalibrated my eyes and was probably better at reading angiograms than I was in my first year of practice because I'd been doing so much imaging. Well, that's not the case. I'm here to show you that my personal experience was the angiogram for me doesn't really help me to get it right compared to how well I do with the OCT. And so I kind of licked my wounds on this and thought maybe I need to go back to reform school and figure out how to read angiograms. But I'll share with you a little anecdote. Quarterly pre-COVID, we organized a complex PCI course called PCI Masters. And in that course, this is an example case I use to go through the nuts and bolts of how to do an MLD Max guided OCT PCI of this LAD. And before, just like in our LightLAB initiative, I'll poll the audience and I'll ask them, what size stent would you place in this lesion? And it's pretty interesting. The angio-guided stent choice for 250 colleagues who are practicing interventionalists are that 45% choose a 3.0, 54% choose a 3.5, which is what I chose for this LightLAB case when I was asked to put my money down, and then one person chose a 4mm stent. When you actually do the OCT, the distal EEL to which we size the stent is 4.1 millimeters, and the proximal is 4.6. And so the OCT-guided stent choice is a 4.0 stent post-dilated to 4.5. And so I kind of felt a little better about the fact that the angiogram doesn't help me guide well, because it seems to be a common problem, at least with the 250 docs I've worked with in our PCI Masters courses. And so there potentially is a better way to size, and we'll talk about how to use OCT to do that. So we think about cost, and this, Azim, is a little bit of what we talked about earlier. How about the cost of not using intravascular imaging? Currently, 13% of US PCIs are done for in-stent restenosis. That's about 80 to 90,000 cases a year if you do the math. And we know that imaging cuts TVF in half. And so if we could even drop that by 40%, it's going to be a huge savings for our healthcare system. And I don't have time to present this today, but ISR is a bad actor. It has a hazard of mortality, even in non-urgent cases. And so there's a lot of patients, it impacts their care, it's expensive, and it kills people. And so there really is a long view of imaging where we have the ability to potentially save money over time, but that needs to be vetted out in studies. And we also need to kind of have a conversation about incentivizing the healthcare system to do things right over the long term versus just saving intraprocedural costs. The other thing we realized is that there's no standardization on how to do an image-guided PCI, and this makes it hard to teach it to people. And I think Azim, it talked a little bit about this before in terms of how we get our fellows trained. We're all training a little bit differently. So with that in mind, those of us that were sort of active in this space realized there was an opportunity for improvement here. And so we wanted to come up with a globalized standard for an OCT algorithm that's simpler than the Illumine 4 protocol, which I know many of you are familiar with. And so this is a quote from Henry Ford: "If you think of standardization as the best you know today, but something that can be improved upon tomorrow, you'll get somewhere." And so this isn't meant to be an be-all, end-all rigid Bible. It's meant to be a generally agreed upon, somewhat consistent way of doing a modern OCT-guided PCI that's also teachable and lessens confusion. And so most of us that teach in this space tried to kind of get on the same page. So we're all using the same language and doing this in a similar way. So with that in mind, we got together in Boston in January, a bunch of colleagues led by Nick West, and tried to kind of work through what the recommendations would be in terms of how to do an OCT-guided PCI. And I'm happy to share with you today the product of that, which is the MLD Max workflow. And so over the next 20 minutes or so, I'm just going to walk through a test case in terms of how to use a co-registered OCT to do a modern MLD Max guided PCI. And I'll explain to you what MLD Max means. But before I do that, I'd be happy to entertain any questions or comments on what I've already presented, thoughts on this from Azim and colleagues, or if I should just kind of get moving, I'm happy to do that too. Anything to add, Azim and friends who are on the call?
I'm just, we usually wait to see if anybody makes any comments via the chat.
Great.
There haven't been many right now, so maybe just continue with the case, and I think the case usually will generate a lot of questions, Kevin.
Perfect, thank you, great. So for this particular part of it, we're going to go through treating this LAD in an OCT-guided way in extreme granularity to kind of talk about this modern workflow that we've been studying in the LightLAB protocol, really to have a conversation about how we're doing this actively. And for those of you that are looming for investigators, I apologize, this is probably old hat to you, but I think it's helpful to get everybody on the same page, kind of get some assessment of whether there's agreement on what's being recommended, especially for high-end users, and have a conversation about whether it's worthwhile popularizing this going forward as we train our fellows and train other colleagues on how to do this. And so the OCT clinical decision-making as follows. The pre-PCI OCT allows you to strategize what you're going to do, and you'll see how this strategy changes your plan when Haram presents our LightLAB data next week. The acronym is MLD. First, you assess morphology, you determine stent length, and then you examine diameter. And I'll show you how to do this very quickly. And so this is an OCT-guided pullback of the lesion in question. And thinking about morphology, really what we care about with morphology-guided lesion preparation is we go from lipidic to fibrotic to mild to moderate calcium to severe calcium. We're really going to change our lesion preparation strategy. When we see moderate to severe calcium, obviously we're thinking about more advanced, more aggressive lesion prep and or atherectomy and or lithotripsy. And what we know, this is a really nice study from the CRF group, which looks at the impact of calcium on stent expansion. When I was a fellow, we used to do atherectomy, and I would articulate this. We're going to do roto because we need help getting the stent down. That's changed. The reason we do atherectomy now is not only to get the stent there. Stents are so deliverable now with guidelines, you can almost get them anywhere. But we really need to work on getting them to expand well, because that's the holy grail in terms of improving patient outcomes. And so if you look at this particular example, it's quite nice. As you augment the amount of calcium in an artery, going from either 90 to 180 degrees in the scoring system, you get 1 point. If it's greater than 180 degrees in an arc of calcium, you get 2 points. If the calcium thickness is 0.5 millimeter, you get 1 point. The nice thing about OCT is because you don't get acoustic shadowing, you can actually measure the thickness of calcium. And if the calcium length is greater than 5 millimeters, as you can see here in this longitudinal view at the bottom, you get 1 point. As the score goes from 0 to 4 points, you see dramatic drops in stent expansion. So this is helpful, and I'd love Azim's thoughts on this. Even within our lab of 7 or 8 operators, there's varying thresholds of when to do atherectomy, and it's not something that's widely agreed upon. Part of that is there's really never been an algorithmic approach of when to use aggressive plaque modification. So I'm hoping in the future, bits of information like this, of imaging's impact of burden of calcium, how it can actually affect stent expansion, is something that may be able to inform our conversation of what is actionable in terms of doing an atherectomy PCI. And so we talk now about the rule of 5 in terms of when you think about doing advanced lesion prep, 0.5 millimeter thick, 5 millimeters long, 50% of the vessel arc. And during every case we do now that's OCT guided, we articulate this messaging with our fellows. What do you think about the arc? How long is it? Do we need to do rotational atherectomy? So I'm constantly pestering them in our cases to be able to make these assessments on the fly, because if you see a large number of these features, it's time to think about advanced lesion prep. Zim, you direct a lab with a lot of different operators. Consistency of atherectomy, is that something which is highly variable in your center too?
Yeah, absolutely. I think it's, it's a question of how comfortable people feel with the device. Having said that, I also think we're now going to have, more devices. I think lithotripsy is going to be an important addition to our armamentarium for calcium. And I think we have to get by, past that just we see the angiogram, we see calcium, and so calcium means atherectomy. I think, now that we have a number of different devices that we can use, it makes only sense to be able to use the intracoronary imaging to guide even not just the question whether you need more than a non-compliant balloon, but also, specifically what device may work better. And I think we're starting to learn that some of the European data, from Disrupt CAD 1 and 2 is also showing us that even with lithotripsy, it may work better in certain types of calcium versus others, so more concentric calcium versus very eccentric calcification. The device can be very different. I am going to also maybe ask, Miguel Alvarez to make a comment. We always, I want this to be about the fellows, Kevin, not just about me and you talking.
Yeah.
So Miguel is one of our interventional fellows, one of our 4 interventional fellows. Unfortunately, we're about to lose them. They've been a superb group and, have really gone. But I think I really want to get some comments out of Miguel at this stage on, as he's finishing now his fellowship and going into becoming an attending, how he's going to think about calcification and using atherectomy. Miguel?
Yeah, hi. Thank you, Dr. Croce. One question that came to my mind hearing you speak about this is, you talk about the penetrance of imaging and how much we do here in the US, but, most operators, as you said, are not used to doing it. And what is your advice for us as fellows going out into practice who feel moderately comfortable with using imaging and who are going to labs where perhaps there's not as much penetrance of this imaging? How should we approach it? When should we decide to use it to be thought of as, reasonable operators and not people who are using imaging sort of indiscriminately in the eyes of people who don't use it at all?
Yeah, you don't want to be me with the cowboy hat out on a limb alone when you're a junior person. I completely understand your commentary. So, we often get asked that, how do you move forward, especially if you're in a place where this isn't part of the usual practice? And so, for fellows, even I have a little bit of this on the last slide, if we get to it in the talk, how do we move the needle effectively? So you want to do it gently as a new faculty person at a hospital. And so doing things like a cath lab conference, showing imaging cases that they've never been shown before, working through what your algorithm is on how to do an IVUS or OCT-guided PCI, a slide here and there, and I'm happy to give you the intro set in terms of the impact of imaging on outcomes for patients. And so it's okay to move gently in your first job, especially if it's not in line with the political culture. But if it's not in line with the political culture, it's not a reason to lay over and play dead. I think it's important enough that if you believe in it, you have to advocate it for it. And you can do it gently. You can do it leading by example. You can teach your techs, you can offer to help your partners, and you can make it part of the conversation in terms of how work can be done in a high quality, precise way in your lab. And the other thing is, you kind of have to commit to it, because if you don't do an IVUS or OCT for your next 6 months as you go into practice where it's rarely used, these things atrophy a little bit. And so it's nice just to keep going at the rhythm you're on and make it part of your daily practice. And I think the more you do it, the faster you get. We've seen that with LightLAB. The amount of time it takes me to do an OCT-guided PCI now versus a couple of years ago is dramatically different because there's just muscle memory to it. And I'll talk a little bit about the efficiencies of how you use this in cases to get a little bit quicker. But those are great thoughts, and it's something that we're often asked. The other thing is, for someone that's doing no imaging, I've often been asked, how do I start? The data are clearly that there's a benefit in complex PCI, without question. And so, complex PCI for IVUS XPL was defined as a stent length greater than 28 millimeters. If that's a complex PCI in my lab, and I'm sure that's a pretty easy day, but if you want to sort of, if you're worried about being accused of using it non-discriminately, anytime you've got a stent that's 28 millimeters or more, say, hey, listen, there's clear data that there's a value here. I'm going to start at least as this is my stepping off point in a new practice, and it really is validated quite clearly. And so that would be a simple way to entree, and then you can back into using it more broadly as it was done in Ultimate.
Got it.
Great.
Just, sorry, quick question here that is directly related to this slide you're showing regarding the calcium, and it's a question that I've had also when assessing these lesions by imaging is, does the depth of the calcium that you see help you decide on whether you use rotational atherectomy or not?
It does. And this becomes a very long conversation, which actually impacted me last Monday when I was treating an osteal LED in a patient with bad kidneys with intravascular ultrasound. trying to do a minimal contrast guided PCI, and the patient had a calcific nodule in the ostial LED that was pretty difficult to dilate. And I think I under-recognized on the IVUS how thick it was. And I put my stent in and it looked like a god-awful oblong D. And at that point, there was not a lot you can do other than high-pressure dilation. And eccentric nodules, if you overdo them once the stent is in, they tend to perforate. So you have to be careful in that situation. So, you know, had I done OCT in that case, I probably would have had a clear idea of the thickness. And I might have considered actually using an atherectomy strategy to debulk it a little bit. So eccentric calcific nodules are places where thickness matters. It impacts the elliptical or circular nature of stents and can impact your ability to get good expansion. And so it's a place where I think being able to measure thickness is helpful. As the example in the middle panel here, you know, this is 1.5 millimeters thick and it's nearly 360 degrees. For me, that's always an atherectomy case because the stent is not going to expand well in that. And in our ISR program doing brachy, we see lots of multi-layer stents placed into lesions like this. And at that point, once the stent's in, it's really hard to remediate them and get them open. But that's a good question. And, you know, it's not just thickness, it's arc that we integrate. And it does flavor to Zim's point, whether I'm thinking about using orbital or roto. You know, James Spratt has a really nice algorithm that sort of suggests ways in which an imaging profile might change the choice of which atherectomy device you use, especially if you have all three on yourself. And we'll hopefully have coronary lithotripsy over the next year or so, which will become part of that conversation. Thanks, that's great. And so with that in mind, you know, the thing we know from OCT studies looking at outcomes is minimal luminal area of the stent really dramatically impacts how patients do after they undergo PCI. So remediating calcium and getting good expansion is really the holy grail to getting at the heart of the thing, which most dramatically impacts MACE in patients. And so this is, and I'll just go through this quickly, but thinking about calcium-dependent lesion preparation, small area, significant calcium burden, atherectomy is able to reduce the thickness of this. And what you eventually want to see is you're actually able to get these fractures at the point of thinning. And that's what is the hallmark feature of being able to get a stent to expand well. You know, Richie Schlafmitz, who's across the water from you guys, uses OCT iteratively during cases, looking for these fractures to decide when he's ready to place a stent. And I know colleagues in Japan that are very facile with OCT do that too. We haven't so much really made that a prescriptive part of our commentary, but in cases where the balloons won't expand, even after I've done atherectomy, I will do an OCT to try and figure out what's going on. And so if you wanted to get really granular in terms of algorithmic when to place a stent, there's people that are trying to push the needle that way, knowing that this is really, this fracture feature by OCT is really commensurate with knowing that it's time to be done, you're ready to place a stent. And those have been correlated, the number of these with stent expansion and the ability to get the stent nice and big. And so this is a test case of the LED I showed you. And pretty much you grab the OCT cursor, you go back and forth and you look to see how much calcium. There's some islands of calcium here, but in no way does it meet any of that rules of 5. And so in this particular test case, the first part of the MLD is assess the morphology. There's no need for advanced lesion prep in this case. I'm just sort of showing you how to do that. You grab the cursor and you scroll back and forth within the area where the lesion is. We routinely use this middle section, which is the graphical plot of the lumen area, because it gives you a nice hourglass of where the lesion is. And obviously it's co-registered with the OCT. We talk about OCT being 4-dimensional. You get a longitudinal view at the bottom, the area map, the cross-sectional view on the right, and the co-registered angiogram. And the workflow becomes really easy because the certainty of where you are, where you're treating, and what you need to do becomes very prescriptive in terms of running the modern OCT-guided PCI. So after you've determined the lesion morphology, the next thing you want to do is define the length. The way you do that is we often will use this OCT 3D luminogram. This shows where it corresponds to the co-registered angio. As you well know, the little white cursor here shows you where you are in the cross-sectional view relative to the artery. And in this particular example, you pretty much will just take this and try to identify the normal landing zone. So you kind of go to the segment, which looks like it will be normal. You see that there's normal artery there. That's going to be your distal edge. We're going to go proximal, scroll around, and try to find the most normal segment. And unfortunately, biology doesn't always give us normal arteries to land in. You can see the most normal segment proximal is here, with some presence of a lipidic plaque in the left-hand corner, but it's the most normal segment. I think this is a safe place to land into. The distance is 35 millimeters between these 2 points. You want to kind of adjust your goalpost of where you're going to land. to the next available size in a commercial stent. In this case, we chose to put a 23 in, so you move the goalpost in a little bit, and you can see you're still in a normal segment, and you're able to choose a 33 millimeter stent at this point. And so here we've kind of quickly in the MLD Max workflow defined the length, which is 33 millimeters, going to most normal proximal to completely normal distal. And so with that in mind, then we want to kind of go through and do this in example. I'll show you on the particular test case. You scroll back and forth. You can see this is a good segment here. You do the same thing proximally, going back and forth, panning to see the most normal segment. You choose this frame here, 35 millimeters. Bring the goalpost in on the left a little bit. Still normal, and you need a 33 millimeter stent. So we define the length of the stent very clearly based on normal to most normal proximal. The next thing we need to do is define the diameter of the stent. The way in which we do modern OCT guided stent sizing is we use the external elastic lamina. I took out the image interpretation slides for this. I can put them back in and send them to Zim and the colleagues if you want to go through. I have sort of a catalog of normal arteries and how it looks and how to find the EEL. But for a bit of simplicity, the EEL is this black stripe which is seen in the wall of the artery. And this is where we size our stents to because it gives you a relatively aggressive stent sizing strategy. In arteries that are severely diseased, such as on the right, you can see that the EEL is not visible. When it's not visible, we're going to size to the lumen. So the way you do an OCT-guided stent size is you, in two orthogonal views, you measure the EEL, you take the average, and you round down to the nearest stent size. In cases where the EEL is not visible, you measure the mean lumen size, which is calculated automatically on the software for you, and you round up to the nearest stent size. EEL sizing tends to give you a little bit bigger stent, and this is good. If you can see the EEL, by default, you're stenting either into a normal artery or into a fibrotic plaque, where there's a little less risk of edge dissection. If you can't see the EEL by default, it's a diseased artery, and you have to be a little more careful with sizing because there's obviously more risk of edge dissection in diffusely diseased segments. And so the cool part is if you want to try this over the next month, it's kind of fun to see. As you do EEL sizing versus lumen sizing, you'll notice EEL sizing typically gives you a stent size that's about 0.5 millimeter bigger. So the reason this algorithm works kind of nicely is it's got built into it the fact that in heavily diseased arteries, you're a little more measured. You go a little smaller with regard to your initial stent sizing, which will lessen the chances of getting edge dissection. So we built the algorithm this way to be aggressive when you can, when landing in normal segments, and being a little less aggressive, a little more measured if there's diffuse disease, trying to avoid the implantation of stents where there's going to be an edge dissection. So as you know, Lumion 4 uses EEL guidance to size stents when possible. So it really tracks with the method being used in the clinical trial, which is hopefully going to validate OCT with regard to outcomes. So the nice thing about using the MLD Max workflow is you'll define your length of stent, your diameter of stent. And at the same time we're doing the analysis, we're going to choose right away what our post-dilation strategy is. So the next thing to do is determine how big you're going to post-dilate. And the way you do that is if you can see the EEL, you're going to choose the post-dilation balloon rounding down to the nearest balloon size. If you can't see the EEL, you use the lumen and you'll round up to the nearest balloon size for post-dilation. Now, I'll typically take one balloon distal and one balloon proximal. And what we've done in this LightLAB initiative is we've operationalized this for efficiency. You do your pre-PCI OCT, you determine your stent length, diameter, and the size of the 1 or 2 post-dilation balloons you're going to use. You implant the stent and you post-dilate it. And what I do in my lab is after I get this information very quickly, I ask my team to get me the appropriate size stent and open the 2 post-dilation balloons. This allows me to recoup some of the time it takes to actually do the OCT. It makes stuff faster, and all of the equipment and procedures are now being guided very rationally based on the OCT sizing protocol. And so it makes it a little bit quicker to be able to do this. All the gears open, you can actually move through the case very nicely. So this demonstrates how you do the stent sizing. We obviously use the distal edge because that's what we size our stents to when we're doing image-guided PCI. We draw a line where the EEL is in 2 orthogonal views. You can see here that the average is about 3.3, 3.03, 3.03. And so in this example, we're going to be choosing a 3 millimeter stent based on the distal reference. In the proximal segment, there's only one axis of EEL visible. It measures at 4.36. So we're going to downsize to 4.0 in terms of the post-dilation balloon. So right away, we know the length of stent, which is a 30 by 33. And we already know the size of our post-dilation balloons, and all of that is open on the table, and very quickly the stent is implanted and post-dilated. So that takes you through, you know, the first part of this, which is the pre-PCI OCT, where we strategize MLD, pick out morphology, determine what vessel prep's needed, determine length, determine diameter, implant the stent, post-dilate it, and then next you do your post-PCI guided OCT. Hiram's presentation next Thursday will demonstrate the efficiency of getting to good expansion using this workflow. It'll be something which we'll be happy to share with you once the presentation is out. And you'll get a nice view of how this impacts the number of times you actually need to do something in the artery, because we've been able to show you get very good expansion a priori after the stent is implanted and post-dilated using these parameters to look to guide stent implantation. And so the next part of this is when the stent is implanted, you're going to do your post-PCI run to optimize, and we're going to look for presence of medial dissection, examine apposition, and think about expansion. This is the max portion of the algorithm. So this is the software view of what it looks like after the stent is implanted. My eye is automatically always drawn to this graphical area map because it shows you right away in an automated fashion. And this is facilitated because OCT is so high fidelity that the computer is able to make all these measurements for you. I'm showing you the dual reference mode here, where the stent expansion in the proximal half of the stent is referenced to the proximal lumen area. The expansion in the distal half of the stent is referenced to the distal lumen area. There's a couple different ways to do this. You can use a tapered mode. I won't belabor that for today's presentation, but we can talk about it a little bit later if there's interest. And so if you think about this, the first thing we want to do is look to see whether there's medial dissection at the edges. That's the M in max. And so the recommendation is if you have a medial dissection which disrupts the media, especially if there's intramural hematoma, that this warrants treatment. And we recommend currently that if the medial dissection is greater than 1/4 of the arc, 45 degrees, it's worth considering treatment. We chose 45 degrees because 60 is validated in the literature, and it's a little easier to remember 1/4 of a piece of pie. And so effectively, when we see medial dissections with intramural hematoma, those are recommended to be considered for treatment. These small intimal disruptions, which you'll see typically on OCT frequently, aren't actionable because there's not a lot of data that they do anything, especially when they're proximal. And so we tend to want to treat big dissections and leave small intimal disruptions alone because we know that clinically they're not important. This is validated in OPCI2, where we see that distal edge dissections have a hazard of MACE. Interestingly, the distal ones are much more noxious than the proximal edge dissections. And Azim, maybe you want to ask your fellows why they think that is. Why do we care more about distal edge dissections versus proximal ones in terms of treating them because they have an impact on MACE?
Miguel or Shun or Mike?
I would guess it's because that impacts the outflow of the stent.
Great. And how about the proximal ones? We really worry about medial dissections and raising flaps and hydraulic tearing down and propagation. Why doesn't that happen at the proximal edge?
Well, I guess the stent is tacking down the dissection, right?
Exactly. It has nowhere to go. So mechanistically, that's probably why distal edge dissections are worse. They impact outflow and they contract because there's not a stent to prevent it. Great job. That's awesome. And so, you know, the recommendation here is if you see a dissection that's distal, they're probably more actionable than proximal ones. And so I think that's something to be mindful of in terms of where the data recommends that we treat these. And so looking at our particular test case, this is really straightforward. As you know, you grab the cursor, you go back and forth. The edge of the stent looks fine. We're now going to pan up proximally to the long view. You can get there very quickly using the software. You'll go back and forth. You can see the stent struts marked by the computer here. There's a tiny little intimal disruption, which is not actionable. This doesn't need to have anything done. There's no major medial dissections here. That part of the algorithm is complete and done. Next, we're going to look at apposition. Miguel and fellow colleagues, this is kind of an interesting thing to talk about because when I was in your shoes, based on IVUS, we used to chase apposition all the time as being something which impacts major adverse events post-stenting. This has evolved. Apposition actually is not nearly as bad an actor from a MACE standpoint as we used to think it was. We recommend considering treating malapposition if it's longer than 3 millimeters in length and if the stents are greater than 300 micrometers or 0.3 millimeters from the wall. The best thing to probably do in this case is to dilate with a semi-compliant balloon so it'll grow to the shape and size of the artery at a relatively low pressure. You don't need to hammer this with an NC balloon. You really just want to get the stents to touch the wall. And what we know from OPCI is that malapposition doesn't really have a hazard of MACE unless it's associated with underexpansion. And so in my practice, I've become more tolerant of little bits of malapposition, especially in the first 2 or 3 millimeters of the proximal LED, where it tapers significantly. The times when this can be a pain is in this example here, where you have 7 millimeters as shown in the long view of malapposition. The stent is completely malapposed, and if you ever had to recross this, it can make it miserable. So in this particular case, I would treat this, but it's with full disclosure that the data behind treating malapposition is not where we thought it was 10 years ago. Azim, how do you guys handle this? You know, this is sort of something which I think the data have evolved, but there's a lot of discordance. Some people chase malapposition, some people don't. It's very readily visualizable by OCT because of the high fidelity. And you do a lot of IVUS. So I'd be interested in your thoughts about, you know, how many millimeters in the proximal LED and what distance is something that you worry about versus not worry about.
Yeah, that's a great question. And, you know, I want to reiterate for the fellows what you said. You know, if you go back to the initial DES days and, you know, Cypher, Texas days, they were, you know, we published a lot of papers. I think I've even published editorials.
Yes, you did. I know. I read them.
Of malapposition and, you know, and how that can impact outcomes. And I think the malapposition that probably can impact outcomes is the late acquired malapposition, right? So it's not the malapposition where you put a stent, you leave, you know, a couple of millimeters malapposed. It's the malapposition that happens in acute coronary syndromes where you implant a stent in thrombus and then you come back a year later and the entire stent's malapposed, not just, you know, a few millimeters. So I think we've learned that the kind of malapposition you've shown, you know, where it's 1 or 2 millimeters at the stent edges is probably not impactful for stent thrombosis, which has been always our biggest concern. On IVUS, you know, we see it as well. We correct major malappositions or long areas of malapposition. We don't have the high fidelity imaging you have with OCT. So when you see malapposition IVUS, it's a little bit more, you pushed more to correct it because you're not seeing it. I think if you see it, it probably is there and it's more significant and lasts for a few millimeters. I guess the ones I'm most concerned about are either in the left main or in the proximal main branch before big bifurcation.
Yes.
Right? Because I always worry about my colleague who's going to come later, whoever's going to come later, that patient has a restenosis or needs to be treated again, and I haven't opposed the stent well, that they're going to then either damage the stent, you know, accordion the stent to get longitudinal stent deformation, or have a challenge of getting back into a side branch or getting back down that vessel. So I almost feel it's, you know, it's my duty to make sure that stent's well opposed if that patient will ever to need intervention again. But I completely agree with you that most malapposition doesn't result in adverse outcomes unless associated with underexpansion.
Agree. And this is, you know, this is an OCT 201 topic, but I think you bring up a great point. In the proximal LED, because the artery bends a little bit, the OCT and even the IVUS catheter tends to not sit at a 90-degree angle. It's a little bit off axis. And the measurements of the artery there can be, because of that off axis, can be made artificially a little bit larger. So when you're thinking about addressing malapposition, especially the proximal LED in that case, understand that there's a slight potential increase that the measurement's bigger than the artery really is. And be careful, if you make a measurement on the proximal LED, but your balloon crosses the D1, where there's a big step down in the LED size, be careful. Don't oversize the balloon, because that's the 1 or 2 cases we reviewed where people have taken overly large balloons, crossed the D1, and ended up with a perforation. So it's important to understand what's going on, and particularly that segment of the artery, because you want to understand the geometry, understand how vessels taper. And sometimes you've only got 4 millimeters before that D1 comes off, and we only have 8 millimeter balloons in our lab. So chasing malapposition, albeit important, probably best done with a non-compliant balloon, not at a high pressure, and think a little bit about what sizing there, because you don't want to get it wrong, oversize, and lead to a papyrus or some other thing that would be an unwieldy outcome for the case. So that's kind of absolutely. A little bit of and so that's sort of a little bit of a deep dive in terms of this algorithm, but where you want to sort of be mindful anatomically of using it. Thank you. That's great, Azim and colleagues. So moving on now to expansion. Expansion, obviously, as you well know, is holding the lumen lesion close to or greater than the size of the normal reference segment. What we recommend is that the acceptable expansion of the stent is 80% of the mean reference lumen, but optimal, the goal is 90%, and Illumine 4 is testing 90%. We had a lot of discussion about this in terms of making these recommendations. The data for expansion really tracks more with area than percentage, but you know that an area of 5 in the proximal LAD is grossly undersized. And so even though being more than 5 millimeters squared by IVUS tracks with better outcomes, being more than 4.5 millimeters squared by OCT tracks with better outcomes, I think recommending a set cross-sectional area irregardless of where you are in the coronary tree is probably not good practice. So we decided to take a percentage approach to this and recommended acceptable 80, optimal 90. And I think, you know, the idea here is that around 80 is when the outcomes and the areas start to track to be justified within the limited data we have, justifying area with regard to outcomes in image guidance. And so this is the goal, 80 acceptable, optimal 90. And we know that it can be a little bit tough to get to 90 in some cases, especially if there's calcium. This is our test case. It shows the proximal half of the stent and the distal half. And you can see that the stent is expanded only 87% in the distal half. So this is an opportunity for further optimization with the goal of getting to 90. The way in which we do the final optimization is we actually go back and we remeasure the distal EEL. You can see that being done here because we know that the arteries often grow in size after they're stented. The EEL measurement here grew from 3 to 3.27 on average. And so the reason why this happens is probably because of flow-mediated vasodilation. So our original post-dilation balloon of 3 now becomes a 3.25. And the OCT co-registration is quite nice because there's no more high-res cine at the edges. You just pretty much take the balloon up where the co-registered angio shows you need to, 3.25/15 at 22 atmospheres. You do your final OCT and you show that the stent is now well optimized, 100% expanded distally and 100% expanded proximally. I'll make a point. These measurements are made by the computer for you. You do not need to do this. Because the resolution is so high, all these measurements are automated, and it makes this really quick. You can look up at the screen and immediately tell how you're expanded, look at the edges, make sure there's no dissection, quickly look at apposition based on whether this line in the middle is white or red, and the case is done. And so the software here, once you're used to it, it's very, very quick. And Abbott has a new product coming out in the fall of this year called Ultron, which is going to make this interface look like an iPad. There's going to be artificial intelligence identified sizing of the EEL and of calcium. So the goal is to make this really, really simple to people that are non-imagers. So even learning this OCT interface is something which is going to hopefully go away with regard to ease of use, making this easy. And the Ultron software is going to follow this MLD Max workflow. So you're sort of mind's eye in terms of how to go through an OCT. You're almost going to be prompted by the software on how to do that. And so we're really trying to help the team that sort of supports this technology make this easy and make this teachable. And so obviously this is just by way of review. The post-PCI optimization is MAX, rule out dissection, treat it if it's distal especially, address apposition if it's major, and deal with getting the stent to at least 80% expanded, but preferably 90. We've got a couple teaching tools which the Abbott team can do where the entire workflow is sort of boiled down into one piece of paper, which can be printed as a laminated card or hung up on the wall. The other thing about this is once you're practiced at it, it does not need to be a Ph.D. dissertation in imaging. You can do this really quickly. This particular case was done between 12:30 and 12:55 for 2 OCT runs and a beautifully optimized PCI. This is the one pager in terms of how to do this with all the recommendations. Happy to give this to Azim and the team so you guys have it on hand. And then I just had a final thought, and I think it's an opportunity for where imaging and physiology lay in our practice in the future. You know, lots been made of the ischemia trial. We all know the elective PCI shows no MACE benefit. That's been a long understood bit of data. But I just have a question, and I'd be interested in colleagues and the fellows' thoughts about this. If we take modern PCI tools, RFR, IFR, OCT, IVUS, that we know are way better than the angiogram, and we use these such that about 40% of our patients aren't either undertreated or overtreated, such that a quarter of our patients aren't left with abnormal resting indices, which could be addressed with different stenting. And, you know, we drop our TVF rates in half by using image guidance. You wonder if elective PCI might finally be able to show improvements in hard endpoints if we actually get the MACE rates reduced and treat the right patients. And this is something I don't have an answer to, but I think clinical trials that are upcoming will help us to start to answer some of these questions, because the indices of the multiple points we can get this wrong based on the angiogram are in choosing patients who to treat and making sure the stents are optimized and making sure we prevent patients from having ISR and target vessel failure. So this was published last month by Sunil, and I love this. It was actually, I sent him a note that I really celebrated his willingness to do this. It's a viewpoint in JAMA Cardiology, and it talks about performance metrics to improve quality in contemporary PCI. And my favorite statement was the comprehensive use of physiologic testing to identify ischemia and imaging to optimize our contemporary features of high quality PCI. I agree with this completely. You know, my summary was it's time to raise our expectations. And that's why we've put our imaging penetrance percentage-wise up as one of the slides in our monthly cath lab M&M, just to see how we're doing with regard to trying to get better at both physiology and imaging. So back to Miguel's point, how you get this out. You know, there's a pretty active imaging following on Twitter. We tweet imaging cases. I make our fellows show the primary imaging data at a cath lab conference whenever it's applicable and interesting. We talk a lot about MLD max. It's actually one of my epic smart phrases is that the MLD max PCI workflow gave me greater than 80% OCT stent expansion. So my referring doctors are starting to get an idea that I'm using a tool to make the stents big. And so little things we can do to try to spread the message, or what we're doing to try and really amp up our game from a quality and a utilization standpoint for, I think, technologies that have a place in our practice and are maybe currently underutilized. So with that in mind, that's the last slide. And, you know, there's a bunch of hashtags which are used in this space, which I think are kind of fun to popularize it. But I really appreciate the opportunity to speak to everybody, and hopefully we can get together in person soon. So thanks very much for the welcoming and having me here. And it's really nice to see everyone virtually.
Thanks, Kev. That was really fantastic. And I couldn't agree with you more. I really do think that, you know, in modern day PCI, the difference between, you know, an excellent center and every center is going to be how we use modern tools to optimize the outcomes of our procedures so that patients have better long-term outcomes. So, and I think, you know, using imaging, intracoronary imaging, and I'm one who pushes that. For me, it doesn't matter whether you use IVUS or OCT, as long as you're using imaging to get, you know, better outcomes. And I think the data supports that. And, you know, the other probably statement I love from, you know, Antonio, who's been my mentor, is that, you know, intracoronary imaging, whichever one you use, doesn't work by intention to treat. So it doesn't have like magic properties. Just by putting it in the artery and taking it out, you now have better outcomes. You actually have to use the information you get. And if it, you know, and even for experienced operators like you, you've shown how it actually impacts your outcomes, that you use the information and you are a better operator and you get better outcomes as a result of it. So thank you so much. I hope you have a few minutes for questions. Do you, Ken?
Yeah, I'm no rush. Happy to stay and chat. Thanks.
Fantastic. I'll pass it on to Miguel. I know there were quite a few interesting questions that came up in the chat that I'll have him address with you.
Great.
Yeah, thank you, Dr. Croce. That was really great. One question I have is, you know, it's also related to the question I asked before. So you really should advocate for the use of physiology and imaging in contemporary PCI in your view. And so what is your practical approach to this? Say you're doing a diagnostic possible PCI, you see a 70% lesion in the middle AD. Do you go for FFR or RFR or IFR and then switch to imaging to assess the morphology and determine the length and diameter of the stent, or how do you do this?
Yeah, so it's a great question, Miguel. And I have to be honest, I use a ton of resting indices to physiologically map the artery. You know, in one of the teaching decks I have for fellows, I have an old slide where I used to say that FFR was used to decide whether to treat, and imaging was what's happening in the artery and how to treat. And then I had the new version of that slide where now, because we have resting physiology, IFR and RFR, we actually use that to map the physiologically important lesions. And so that practice has even evolved in the past couple of years. And so in a diagnostic case where there's an uncertain lesion, I will certainly use a resting index and do a pullback to map out the physiologically significant portions. And then, you know, that helps you to evolve physiology, not just from a whether to treat, but also a where to treat. And I think Define PCI showed that quite nicely. There's a bunch of beautiful case studies from that where, you know, colleagues will show an artery where the lesion, which is treated angiographically, isn't even the worst of it. And so this is where the imaging becomes complementary, because I have to be honest, a lot of times a resting pullback will show me significant drops in pressure in places where I don't expect it based on the angiogram. And I, for 10 years, I've been using an angiogram. I kind of scratch my head. And even to this day, I'm like, do I believe it? But I'm often going to do a pre-PCI OCT for planning anyway. So that gives me a second check based on the resting physiology. And I have to tell you, it's almost always right. And so the resting physiology helps me to determine where the most significant lesions are. And I start to think about what the goal of treating to a normalized IFR, RFR is. And then the OCT often tells me where the edges should be of the stent. And so where to treat becomes a hybrid approach now of resting physiology pullback and then imaging to guide exactly where to stent to and how to get the stent perfect. In the future, there's a study coming out called Fusion, which is going to see if OCT can be used to predict FFR. That's a new technology where you might be able to get physiologic assessment from an imaging catheter. That trial is going to start this year, and many centers are going to help to validate that. It's at least experimentally validated. So I am cost conscious. I mean, there is some extra cost to doing an RFR and an OCT in a case, but I think it is consistent with modern practice, and the data certainly tracks with that. A new 5-year long look at FFR just out this month showed a mortality benefit to physiology-guided PCIs. And so you could build a very similar talk track to what we just went through for imaging all along the physiology side. And so I think the two are very complementary. And as Sunil said, they really are the hallmark of a high-quality modern PCI. Great question, though.
Thank you. There's a question here from Mike. He's one of my co-fellows, and he wants to know, how do you guide your decision to reach for IVUS versus OCT when you're doing a case? Is it all based on contrast limit or?
Yeah, so I didn't have time to talk too much about this. The LightLAB workflow, one of the things we're doing to not increase contrast is that the co-registration is incredibly powerful. So, back in 2009, when I was a first year attending, I would place my stent, I'd post-dilate it, and I'd take 2 orthogonal views with the wire in. Stent from one angle, stent from another. I take the wire out and I do a third view. That's a waste of time now if you have a co-registered OCT, because the angiogram gives you no information compared to the high-res OCT run. And so the real safety thing for the final shot out is no wire perf and the left main's okay, because the OCT tells you everything else. And oftentimes you'll see the left main depending upon where your OCT is. And so what ends up happening is we do less angio runs in an OCT-guided PCI, because the co-regged final picture, you get the OCT for free because you're going to do that angiogram anyway. And so we've been able to dramatically reduce the number of angio runs doing this from a procedure standpoint. And so for me, I do a lot of CTOs. There's a really important place for IVUS with regard to, proximal IVUS-guided cap sticking, knowing if you're in the subintimal space, doing iterative imaging. IVUS is a really important tool for complex CTO PCI. But for me, I'm honestly, and as you and I were talking about this at the beginning, I'm more comfortable with OCT because I've used it more. And I'm really, really facile with the workflow. So typically that's my default right now, is I'll do an OCT-guided PCI because I like it, it's fast, it's automated, and I'm very comfortable with the MLD max workflow, except in CTO cases or really, really awful patients with bad renal function, where I tend to be mindful of, IVUS-guided no contrast or minimal contrast. But, for me, OCT is the default because I'm comfortable with the workflow, I like the automation, and I know how to use it really well.
Mm-hmm. Great. And any tips on how to do non-contrast OCT pullback?
Yeah, so I think I'm told that there's going to be a paper published on saline-based OCT this year. There are ways to do it using saline and a pressure injector. As you know, contrast is utilized in OCT because it's viscous. It dwells in the coronary longer because it's thicker than blood, thicker than saline. You need that dwell time to be able to allow the OCT to do the rapid pullback in a blood-free environment. So if you're going to do it with saline or maybe with 50-50, you need to inject a larger volume. You can do that sometimes in right coronary arteries if you have the assist device. My lab only uses manifolds, so all of our OCT runs are with a manifold. But I think, there is in development ways to do this with saline. There are several published papers, one very nice one from Manos Verlakis of a pretty big experience using dextran rather than contrast to do OCT. It's a little hard for us to get. I've done probably 10 dextran runs in my career. It does work. One of the things you should know is if you're going to use dextran or saline, the refractive index of light in those media is different. And there's a little bit of a correction factor in terms of the sizing. And so, a little bit of sort of, 201 differences in terms of how you use it. It's about 1.17, I think, is the correction. And I can point you to Manos's paper if you're interested in that, at least for the dextran piece of it. But that's a good question. Great. So we try to actually have the contrast part of this go away by being smart in terms of the number of angio runs. And you get so much information from a planning standpoint, you don't need to look at the artery with the angiogram as much because you really have clarity based on the OCT. And that's some of the workflow stuff we've been trying to develop in this LightLAB program.
Yeah, one question from one of our attendings here is whether there's long-term outcome data based on the 80 to 90% expansion.
Yeah, no, that's exactly right. That's sort of correlative to minimal stent area. So area is where the majority of outcome data is. And so there is correlative data to expansion and area, which is what's based on the recommendations for the 80-90. But the majority of data really looked at a bimodal cutoff, either by IVUS, 5, 5.5, depending upon what study you look at, or by OCT of 4.5 and OPCI, as I showed you in those earlier slides. And so the hard part about that is in a 6-foot male, 4.5 in the proximal LAD is like dramatically undersized. And so we have a little bit of a hard time rectifying what's an available database versus percent expansion, not wanting to advocate for 4.5 as the rule, because we'd be telling people to undersize stents and big arteries all the time. And so eventually when Illumine 4 comes out, we'll have a validated study which treated to 90%. It'll be interesting to see how often people can get there, even in a clinical trial setting. But the main point is this is sort of a practical point of discussion to get people to size relative to the reference vessel, thinking that that's going to track with outcomes. But I have to concede completely that area is the place where the majority of retrospective and prospective data sits right now.
Yeah, I think that will be one of the interesting areas to see how often you get to that.
Yes.
We did a study with Antonio using IVUS called AVIO years ago. It was the first sort of IVUS versus angio study with drug-eluting stents. And we tried to get to 80% as our target. And I have to tell you, and it was only complex lesions allowed. So, long stents, calcified lesions, bifurcations, left mains. We were only able to get to our cutoff of above 80% in about 60% of cases. And this was from some very expert operators who were involved in the study. So I think we do have now, although now I think with Illumine, 10 years has passed since we published that paper, we have a lot more, I think, devices available that can help us get better outcomes. And I think, one of the limitations in that paper, in that study, was we didn't use the pre-OCT as much to guide the lesion preparation. And I think that's what's changed a lot, is we're really using the pre-imaging to really guide which device we use in a patient.
Yeah, no, Azim, you're totally right. 90% is hard. And in that little working group in January, I advocated very strongly for 80 because the outcomes are probably still excellent. I should say are likely still excellent there. And we didn't want to set up the community for failure, right? You got to get to 90% when we know a lot of the time it may be hard to get there, absent the data from Illumine. But you'll see next week when Haram presents the LightLAB data, how this workflow at the initial post-PCI, after you've post-dilated, what the average stent expansion is. And it'll start to give a little bit of granularity to real-world use of MLD max and what expected expansions are. And so I'll let him sort of present that for a little bit of a teaser for next week. But I'm completely in agreement with you. 90 is really tough, even in super high volume centers that do this at a high level. So, what's a practical place that people aren't taking oversized balloons and we're recommending to do things that are, not going to really impact expansion and increase perforation is something we thought carefully about with regard to getting a standardization. And so 80 was really a measured way. If you can get to 90 in a reasonable way, that's good. And then the other thing, which I didn't have time to go into, is the recommendation is to take a 1-to-1 size balloon, go up to at least 18 atmospheres. And if you can't get expansion at that point, from a practical standpoint, you're done effectively. And so not saying that, you should leave it 40% expanded. There's laser and other things you may need to do to remediate, but going crazy at 78% in a calcified eccentric nodule is probably more dangerous than beneficial for patients. And so there was a conversation in terms of how to standardize this, which was a balance between efficacy and safety. And so your point's very well taken. And practicality. You want to make this achievable for people so you don't feel like, you're never getting there. Otherwise, it's going to die on the vine.
Yeah.
I don't know if we have time for more questions, Dr. Lateeb.
Are we good?
Yeah,
Yeah.
if we have time for more questions, I can ask a couple more that are here in the chat.
If Kev has time, I think so.
Yeah, I'm happy to.
Yeah. One question is, just to clarify that the expansion is reference to the distal vessel diameter and not to the expected stent size.
So yeah, so the distal segment can grow in size. So effectively, it's interesting. There's a little bit of a change in referencing in the middle of the workflow. So we size to the EEL initially as an aggressive stent sizing. But then once the stent is placed, the cross-sectional area of the stent is referenced to the mean luminal area, either distal in the distal half of the stent or proximal half of the stent. And so even though we size to the EEL, because it tends to give you a little bit more of an aggressive stent sizing, that was a bit of a practical approach that came out of Illumian 3 in terms of how to get well-sized stents. And actually well-sized stents compared to IVUS was the initial goal, as you're probably aware. And so there's a little bit of a change of referencing in terms of once the stent is in, you go back to looking at the lumen. And if it's well-sized compared to the lumen area, effectively you're done. With the idea that the stent is meant to taper the artery and make it size relative to the lumen in the proximal and distal segment. The tapered method of determining stent sizing takes into account volumes and branches, and maybe a more accurate way to do this. I think that the Ultraon software, which is going to come out in the fall, is going to default to tapered method of expansion. The reason we're not teaching that now is because it will be confusing, because Illumian 4 currently uses a dual reference mode where you cut the stent in half, you check the distal relative to the distal and the proximal relative to the proximal. We didn't want to introduce too many different workflows in the midst of Illumian because we didn't want to create confusion. Even though I'll tell you, for a new user, the tapered mode is just much easier to use. So we had a lot of conversation in terms of recs there, but in time it's going to evolve to tapered mode is my sense. And one of the projects we're looking at is in the 700 or 800 angioplasties we have so far in LightLAB is the difference between dual reference and tapered mode in terms of expansion, if they give us the same information or if they give us different metrics in terms of how often we get good expansion. That's something we're doing with Haram actively as part of a research project.
Miguel, maybe the last two questions on the chat, and then we'll let Kev go.
Okay. One is also from one of my co-fellows, and is you sort of touched on this software that's coming out and to facilitate the use of OCT. Is there going to be any integrated technology to tell us about the morphology of the plaque and also about the length of the stent in terms of where's the most healthy portion to land the stent in to facilitate interpretation?
Yeah, so I've seen, it's highly under cloak and veil because of some of the cool IP involved, but I have seen some of the early functionality with regard to screenshots of the new software. The 2 points which are pretty cool are the workflow is going to be easy and the interface is going to be really simplified. Miguel, I've been doing OCT since it pretty much was approved, and that whole interface, the software we went through today, it's like a pillow. It's warm, it's comfy, I know it well. But I think maybe I'd be interested in your thought. As a new user, you pull up to that thing, there's buttons everywhere, menus everywhere. It can be intimidating, we learned. And so, the goal is to make it simple, which the interface will do to hopefully improve adoption and make it easier for people. From a functionality standpoint, I think the two most useful things is that there's going to be artificial intelligence detection of the EEL. So all that drawing orthogonal views and finding the EEL will go away. I'm told by the engineers it's highly accurate. And there's also automated calcium detection. And so you can scroll back and forth and almost get a volumetric look at how the calcium is, which is pretty neat. And it'll be interesting to see what the menus look like and how it's represented. We've given them some input in terms of how to show it to an interventionalist in a way which makes it accessible and actionable. I'm also told, I can't confirm this, but I think there's going to be live co-reg such that you sort of, when you're working, you'll be able to see where it overlays with the OCT in terms of devices and stuff. But I've not been privy to actually seeing how that works, but I think there's going to be some workflow improvements which come out also.
Great. One last question here, and just to comment on what you said, I think the general perception, at least when I was learning, is that there's too much information here. It's a little bit daunting, but yeah, that would be great. So one final question here, and it's really somebody in the chat asked it, And I had a case like this. It was a STEMI. What is your experience in using OCT during STEMI? I remember during this case we did a OCT guided stent, and we post-dilated pretty aggressively to the size that the OCT told us. And as a result of that, we had more embolization of thrombus perhaps than we would have had, and no reflow, and then complications with stent thrombosis and stuff like that.
Yeah, and that's, you know, that's a thing where there's not a lot of data. Is it better to be more measured with expansion for, you know, acute sort of success in a STEMI, or a little more aggressive for long-term patency? You know, Azim talked about the fact that a lot of the ISR cases and sort of dramatic stent failures afterwards are placed in the setting of ACS where the sizing has gotten wrong, or is acquired late malapposition, or it was never expanded because the patient's on pressors. And so STEMI is a hard thing, you know. In the other experiences, you know, are you really going to do an OCT at 2 in the morning? 4 years ago, my techs would roll their eyes when I would ask for an OCT at 2 in the morning. And from a workflow standpoint, I think it's really cute. Like, you know, my fellow's getting radial access. We're choosing our initial guide to go up with, and I see someone drop the OCT box on the table outside because they know we're going to be doing it in these cases. But it's because the workflow is really easy. It's part of the cadence because I've done so much of it. And after you do about 10 or 15 cases, it's no longer stressful to pull it during an ACS case. When you do it during ACS cases, especially a STEMI, you see lots of thrombus prolapse through the stents that you don't see angiographically. Typically for me, that's not actionable. That's a pharmacology problem. But I do work more aggressively probably than many to get optimized stent expansion in STEMI, with a little bit of an acknowledgement of the fact that you may get a little bit more thrombus embolization. But I think that, you know, long-term leaving stents underexpanded, which is prone to happen in STEMI, is probably something that's a bad idea, but there's a little bit of difference of practice there. And so I concede the fact that, you know, if you really go big, you may get some of the clot to go down. But typically, you know, the post-implantation PCI, if there's a lot of thrombus, I'll intensify our anticoagulant regimen. We use a reasonable amount of cangrelor in STEMI patients. If I haven't started that yet and there's a ton of thrombus, especially if the angio looks bad because the angio is so low res, I'll use integralin. It's one of the rare cases which I'll add it now. But I do acknowledge the fact that being aggressive in that case does have some downside. There also is an upside to it. And I don't have a right answer in terms of what, you know, there's no trials looking at that particular feature, but it's a good question.
Thanks.
Kev, that was super, very practical. I think we all learned some very useful tips. It would be great if you could share some of those slides you mentioned.
Happy to. I'll send you a link to Dropbox. Happy to give them to you.
Absolutely. And then we'll make sure, if you don't mind, we share them with the fellows, and
yes,
we get the word out there about how to use MLD Max. I'm definitely going to be using MLD Max, and that's my new word. So we'll make sure that everybody on the call gets a copy. We'll post it along with your video of this call, so we can go through it again. I really appreciate it. Kev, thanks for taking the time. Hope to see you soon again in person, and take care.
My pleasure. All the best, everyone. Be safe. Take care. Thank you for having me. Bye-bye.
Thank you. Bye-bye. Thanks, Miguel.
Bye.
Thanks, Miguel.
Thanks.